So if Sarah here has PID, what symptoms would we expect to find? The most common symptom is pain, lower abdominal pain, which is usually bilateral but not always. It's normally of a short duration, less than 2 weeks, and there's very often associated dyspareunia. Often the patient will say that she hasn't been able to have sex at all because it's too uncomfortable. There's commonly a vaginal discharge. This can be yellow or green and is usually foul smelling. It's not always present though, so don't let that throw you off. It's also quite common to have abnormal uterine bleeding. This is normally quite light, like spotting or postcoital bleeding. Patients may have a fever, especially if the infection is advanced, and there may also be urinary symptoms. And this is because the bladder is right in front of the uterus. So inflammation in the uterus and the tubes can often involve the bladder as well, causing dysuria and urinary frequency. Let's move on to our physical exam findings. On examination, the patient may be ill-looking unless she has a very early infection. You may find that she's pyrexial, she might be tachycardic, and then again, if it's severe, she might have tachypneic, and she might even be in shock and have a low blood pressure. You'll find that there's lower abdominal tenderness. This could be local pelvic peritonitis, and it could even be that she has generalized peritonitis if it's a very advanced infection. You may find that she has a vaginal discharge on your glove when you examine her. You'll find that she has cervical excitation tenderness in most cases, unless it's a very early infection, and I'm going to speak a bit more about that now. And you may also find that she has right upper quadrant pain. So why would a patient with PID have right upper quadrant tenderness? So there's a rare syndrome called Fitzhugh-Curtis syndrome, which is where the capsule around the liver becomes infected. This is normally caused by gonorrhea or chlamydia. This infection causes pericapsular inflammation and adhesion formation around the liver, normally to the anterior abdominal wall. It may not be accompanied by the usual PID symptoms and signs, and this is because Fitzhugh-Curtis syndrome can occur as a chronic late manifestation of PID. So perhaps the woman had subclinical PID which was never treated. She may never have known that she had PID, and then months or years later she could develop Fitzhugh-Curtis syndrome. So that's just to alert you to that syndrome. It's not very common, but it does happen. Okay, let's go back to CET. Cervical excitation tenderness. I'm just going to explain why we would get that finding on physical exam and what it is. So when you're examining a patient with PID, you will have to do a vaginal exam and a bimanual exam. When you're doing your vaginal exam, you'll put 2 fingers into the woman's vagina, and then to assess for cervical excitation tenderness, what you'll do is gently push the cervix to one side or the other. As you push the cervix, if there is inflammation in the endometrium, in the tube, and therefore extending to the peritoneum that wraps around the uterus on both sides, if there is peritonitis, it'll stretch that peritoneum and cause the woman severe pain. For a woman who doesn't have pelvic peritonitis, this won't be painful at all and she probably won't notice it. But as you move the cervix, you'll look at her face, and if she's got inflammation here at the peritoneum, you'll see that she's in quite a lot of pain. What are the common differentials for PID? Okay, so the common differentials that we need to rule out in a patient presenting with lower abdominal pain, firstly appendicitis, then complications of an ovarian cyst, so that could be ovarian torsion, or cyst rupture, which causes very similar symptoms. We need to rule out a UTI because there's commonly urinary symptoms like frequency and dysuria. We need to make sure that it's not a UTI. And then the last of the very common differentials is an ectopic pregnancy, which obviously causes lower abdominal pain, CET. It can cause abnormal uterine bleeding. So that is something that needs to be ruled out. So what investigations would we do? You would need to do a urine dipsticks to rule out a UTI. We would need to do a pregnancy test to rule out an ectopic pregnancy. We would need to do an ultrasound in some cases if we suspected that something else was going on. Then, because it's a sexually transmitted infection, most of the time, it's helpful to test for HIV and syphilis if it hasn't been done before, and to do a pap smear. In terms of other diagnostic tests, there's nothing specific. There will be signs of infection, for example, a raised white cell count, a raised ESR, and a raised CRP. But since it's a polymicrobial infection, doing a vaginal swab is not particularly useful, especially since lots of women have potentially pathogenic bacteria in their vagina all the time and never go on to have a problem. So we don't routinely do a vaginal swab.